especially in terms of palliative care. Just to show you the increasing age all over Europe, and in Croatia is the same thing. The last 150 years, people are getting older and older in Europe, and lots of patients need our help, especially when you see that it's not only the patient, the people over 60 years old, it's the patients over 80 years old. Yeah, and that's what we see, because the average age in my ward, it's 85 years. It's the average age of the patients. So we deal for the very old. As Rudi showed, in the palliative care units, the patients are much younger. But what's about the patients who are old? Yeah? Not all of them can go to a palliative ward. It's impossible to deal with the quantity of the patients. Yeah? And this is, I think it's a very good slide just to show you the concept of frailty. I think you have heard about it. People are getting old, they get weak, they have not enough strength, so they are socially disintegrated. Very often they come to the nursing homes, and then they die there. So the older the people, the frailer they get, but the frailer they are, the easier they go to die. So the concept of frailty is very important for the geriatrician to care for these patients, because in a lot of these patients are palliative patients. They not only suffer from pain, they do often suffer from pain, or from oncological problems, or neurological problems. They often suffer from a lot of other things too. Weakness, for example. Heart insufficiency, congestive heart failure, aspiration. Yeah. So we, and that's the same as you asked, it's a long time to go. Yeah, Professor Böhmer was one of the initiators. He was 20 years, he was in charge of the Society of Geriatric Medicine. And in 1992, so 20 years ago, there was a concept, we have to promote geriatric medicine in Austria. And then a lot of steps had to be done. It took 6 years. There's the Austrian Institute for Health took the issue up, and we discussed, like you do now for palliative medicine, on the governmental basis. And the Ministry of Health made the first step for specialization in 2003, so it was 10 years to go to get this point done by the government, and another 9 years to get a geriatrician in Austria. We're one of the last European countries in the EC to have the geriatrician. Now only, I think, Greece and Portugal don't have special geriatricians, but the rest of the European community have. So in Austria at present, it's, we have 724 geriatricians in Austria, which is not much, but it's starting, and these are doctors who are specialized in geriatric medicine. So this is the landscape of Austria for the geriatric wards. They also started in the 90s. So I changed from, I'm learned in doctor for internal medicine. And I changed in 1994, I changed to geriatric ward. And at that time we started at the Kempfjord, which is in the south. Now we have 8 geriatric wards, which is it's the best country from Austria according to the population. So we did a lot of work for geriatric medicine, and we have none in the Western countries, for example. Yeah. So it's still in developing, and you need geriatric wards as a center, like Rudi has a center for pain medicine. You have to have a center for geriatric medicine, not to deal with all the patients, because it's impossible according to lots of the patients, but according to specialize, to train the nurses, to train doctors, to have this concept, this holistic concept, like we have in the palliative care. We have to have nurses, doctors, social workers, psychologists, yeah, physiotherapists. All the team has to work together for the patients. Yeah. So the Austrian Society of Geriatrics and Gerontology is a platform. It's a very important platform because we promote all these issues, and every country has some delegates in this society. So we organize congresses. It's alternately in Vienna or in Germany, in some other parts. We try to have delegates in the European context, and we have working groups like for palliative care, like for pain, quality assurance, gerontotravmatology, all the issues which are very important for the development of geriatric medicine. And we have a strong interconnection with the palliative units. Like we do a lot of projects together with Rodilika. Yeah. Because we take care of the chronically ill patients, of the patients who we cannot send at home. We have a ward for chronically ill patients where the patients can stay for a longer time. But in the acute geriatric ward, the patients only stay for 10 or 12 days. So when we began, it was 21 to 30 days, but there's so much patients, so we have to send them home very early. But as Rodilika said, there's a lot of things to organize so people can live at home. So the concept of geriatric medicine, just one slide, is normally we have a disease, we have a known etiology, known pathology, or unknown etiology of pathogenesis, and then we have a set of signs. And geriatric medicine is contrary, because the patient comes with a lot of factors, social factors, medical factors, psychological factors, and we have to reduce it to one point to get to think how to treat the patients, and that is our main program. Like you do in the medicine, anamnesis is the same. From the manager, he makes a point before he dealt with geriatric medicine, and he developed a lot. And he said on a congress, we have a special tool. It's gerontoscopy. Like endoscopy, we look on the patient on a different point of view. Like I told you from the geriatric assessment, this is a method. We have to know about it, and knowledge, skills and attitude. Yeah? And knowledge we have to train, like Rodilika trains the students, the nurses in pain therapy. We have the same in geriatric medicine, we have to train. We have to train the communication skills. Yeah? This is a possibility to learn. We have the gadgets, but we have the methods. Yeah? And you have to have attitude. And the attitude you can learn, it takes time. But the people who are interested in palliative medicine and geriatric medicine, they bring some attitude into the field. And this we have to develop and then structure clinical processes and bring the processes on the level of the government. I think it's the same thing what I learned from you now, from Mariana, as you go with the palliative movement now in Croatia. It's a very good point to do it. Yeah. So, assessment has a diagnostical dimension. That's what we do in the clinic every day. We are working in interdisciplinary teams, but it has also management and planning dimensions. So how many wards do we need? We are starting a project in Frankfurt in a small hospital where the team goes out. It's like the palliative goes out, also the geriatric team goes out and works together with the general practitioner. And the therapists go to the home of the people, so they don't have to be admitted to the hospital if they deteriorate. It's very important also for geriatric patients. So we will have together, work together also with this team. And there's a dimension of organization and information to build up integrated care models. I think in Croatia it's the same thing. We have to put together all these puzzles together, to integrate them and not to work in parallel structures. And then evaluation. So I go through that. We built up an evaluation project. We developed an information sheet for geriatric patients where the assessment is inside, also all the tests are inside, for mobility, for cognition, for nutrition, for the activities of daily life. And we gather these sheets and they are put together in Graz. It's an institution which is called Healthgate. And 18 wards in Austria now take part in this benchmark system. So we started in 2008, in only 4 years, that was the first beginning with the sheets. 2010 we had 20,000 data sets, and now we have 30,000 data sets, which is very, very important to look behind what can geriatric medicine do, what is the benefit of geriatric medicine, and how we deal with the patients. Also to show people who decide on a governmental basis where we will put the money in the next years. So that's the data from all Austria, that's the data of our institution. We have now 5,000 data sets from our hospital. And if you look behind the data, for example, these are the patients that come with eight drugs at the beginning, and they go with 7 drugs to go home. So 1 drug per patient we reduce, which is a very important thing for polypharmacy. So we can show we reduce medication, which makes the patient live safer, and it's an economical issue. Or, this is a very interesting thing. We can look how live the patient, because we put it into the data. If the patient lives alone, you see about 60% of the patient go home and 20% go to the nursing home. That's the data of my ward, and that's the data of a hospital in Styria. If he lives alone, 60% go home, 50% to a nursing home. And if the patient has a partner at home, nobody goes to the nursing home. And that's very important to show. It's a social issue. So you have to take care of the environment of the patient. If the environment is good structured, and there are people living at home, take care of the people, you can send the people home. And this data we need just to show politicians, to show groups that the work we do is efficient. Okay, I go over that. It's just I'm also the head of the emergency ward, and Rudi Licker told you at the beginning, in the emergency ward, the people get older and older. And if you look at the data, this is the last year, 30,000 patients. The patients who are ambulant, 70% are below 65 years. But when we accept the patient to the hospital, only 46% of the patients are below 65. And 13% of the patients are older than 85 years old. Yeah? And that's the development of the hospital of the future. The hospitals we have, the very old people. Yeah? And 150 patients, they're older than 96 years old. So we have every second day a patient is accepted to a hospital who is older than 95 years old. So it's a huge challenge for the Austrian hospitals to deal with this problem. And I think geriatric medicine and palliative medicine must enter into the emergency wards. That's my deep. I'm convinced of this. We look at after the data now the last 2 or 3 years, because we built up, Rudi has shown you, a huge central emergency department. Yeah. And about 60,000 patients every year run through this department. And if you see the data, more of half of them are older than 65, and a lot of them are older than 85, so we have to take care of these patients. Okay, and just when you Google for Ulla Huang, she's a doctor, she lives in New York. And Ulla Huang described the geriatric emergency department within the emergency ward. That's the development of the future. You have to divide patients. Some patients they go to specialized wards. Also the old one who only have one disease. But the complex patients we have to develop special wards where we deal with them, and there have to be people who know pain treatment, who know to deal with complex situations where psychologists, social workers work together. I think it's the same, like as you know from palliative care. So I think we have to work close together, geriatricians and palliative care doctors. So that's maybe the reason you wanted me to talk about a little bit geriatric medicine. So I only can say, go ahead also for geriatric medicine in Croatia. Thank you for the invitation.
Pitanja?
Ću ja mogu krenuti engleski ili to? I'll comment on English. Some of you went out. When we asked me, and here I want you something to remember. What we do with every lecture, you must have, when the lecture finishes, you must know whether in your head you feel anything change relating what changed in your will. Did something happen with your will? You want to do something. Do you have a goal? Did anything happen with the relation to your knowledge? To gain your new knowledge, or you want to study your knowledge? And did you make a decision to take action? You should know yes or no. And when a lecturer gives you, like you had a very nice lecture like here, he should be able to point with the finger at you and ask, tell me what happened with your will, your knowledge, and your action. If you take it as a passive, you are not chaired here. That's why you are hearing a lecture. A lecture is given to your will, to your knowledge, and to your action. And you have to evaluate yourself, not the lecture. And that's what you should do every time. And it should be good to comment. I don't know when you will be ever again be able to hear such two nice colleagues from Austria. You must evaluate what happened with you because you said to them. You should not think that you were put aside and passive. You are more important in this lecture than they. That you should know that every time.
See, if someone goes for geriatric medicine, I strongly support him. You're always welcome to come to see what we do and to exchange each other. It's a very important thing, I think, for the future.
Next question.
So I'm not so happy with the should and must, but I agree with you. What I would need from you, if you can give me clarification. It sounded to me, I'm not a medical profession, very similar to palliative care focused on the elderly. So what would be the fine line? When do I say it's geriatrics and when is it palliative care for the elderly?
Normally you cannot draw this line, especially in the very old one. You can say every 90-year-old person is palliative, but because he only lives statistically 5 years. But at the beginning, we did a lot of remobilization. We have acute care and remobilization. For the remobilization, especially after stroke or after hip fracture, we try to get the patient back home. That's the main goal of geriatric medicine, also like in palliative medicine, to reintegrate the patient home. Normally we cannot stop the problems they have got, because we are at the end of the whole process, and we only take care of the most ill of them. Yeah. So we have a lot of patients who suffer from heart congestion or from aspiration. So we cannot stop this process. But what we can do is, in a very short time, to reintegrate the patient. Yeah. But the palliative concept, or let's say geriatric medicine without palliative concept, doesn't work. You always have to take in mind the palliative concept. So all doctors working on our ward, and it's almost all over Austria, also have a diploma in palliative medicine. Because as you said, we work together in a team. That's the main thing. Yeah. We have a special technology, yeah, working together and see the patient from different point of views. The doctor still is the promoter. You need one team leader. Should be the doctor. That's what we have found out. But every person in the team is equal to the other. That's the main concept. And I think what I've learned from Rudi, or I cannot speak Croatian, but what I heard in their speeches, I think it's the same concept. But we have the very old one. So the geriatrician also needs love for the old people. If you don't love the old people, if you don't have a special concept of death for yourself, you can't go for it. That's not possible. Otherwise, you're desperate. But I think it's similar, and like in the palliative.
Thank you. Next question, Dr. Devčić.
Okay. This won't be a question, it's just like a comment. It's not a comment of your lecture. The lecture is very good. But for us that try to continue this story about paliative in Croatia, about the management of cancer pain and pain in general, I started to get around Professor Luca in 2007 in ethics school in London. And after that, all these lectures, especially this one today, is like a step on the way to establish some new and good system, to be a part of the European palliative care system. It's very good to be here. I'm not surprised that a lot of people came today to hear some good words from abroad and from Croatia. And it's, I hope we will see again in Croatia as a next step. There was some future lecture next year in the country, on Congress and so on. So it's not a question, it's comment. I try to be interactive. Okay.
So we worked together. It was very nice to work with the Italian, the Slovenian, Austrian, Croatian group together. So it was very astonishing for me, because we have very nice meetings for this Congress in Opatija. I think it's was a very good thing to have all these countries together to develop these issues together.
Yes. I'm sorry the professor has left, but we have some goals and we did some action, and we will be